So, thank you, Balraj. Thanks to all the panelists and seniors here. So, the topic here is minimal soft tissue release. I am Dr. Sai Phani Chandra at KIMS Hospitals. So, what is minimal and what is this soft tissue? So, as we all know, robotics, we have been talking since morning. The main uh, objective is to have less pain, and so is achieved by doing a minimal soft tissue release. The soft tissue envelope around the knee is what we were talking about. So, the knee anatomy, as we know, middle, it's a complex anatomy into three layers. So, which we all know, we don't want to go into much details about it. Next is the lateral, which is more intricate than the medial side, which includes so many structures, LCL, popliteus, and all, including the PCL and the capsule as well. So now, what is the morbidity of this release? Now, why do we concentrate more on releasing it less than more? So if you see that triangle which I placed over it, that is the anterior triangle, which is the first thing to be released to have adequate exposure to begin with first. Now following that, beyond that is what we are talking about, whether we should go beyond that or not. What if we release, what if we don't? By releasing more, we alter the compliance of that joint. Because MCL has a rich innervation of magnoceptors with Ruffini endings and Pacinian corpuscles that provide the proprioceptive feedback, which will be lost once it is released beyond the midcorneal plane or maybe up to the postmedial structures. So extensive stripping or release denervates these on the medial side, so contributing to a loss of joint position sense to some extent. So aggressive release can lead to mid-flexion instability. So the workflow paradigm for any manual on robotic is in this sequence: cut the bone, assess the gaps, release, and manage the damage if any. Robotics is first predict the gaps, preoperative planning, adjust those cuts preoperatively, minimal release, and preserve the tissue. So the conventional things we've been discussing extensively since morning. It is jig based, mechanical alignment, position it perpendicular, and release the soft tissue according to that particular cut. But in robotic, it is planning, record the kinematic profile, manage the soft tissue tension intraoperatively as needed, real-time data, virtually adjusted, and perform minimal tissue release. So this is again how is manual TK balancing strategy and how is the robotic helping there. So it predicts the gaps first. Likewise, the impact on ligament. If you release more, there is point of no return. Once you release, it is done. Whereas in ligament sparing, we will know how much is the tension and how much we have to see, and we can titrate it to our necessity and the requirement of that particular joint. Now coming to wound environment again, we have extensive stripping in manual TK for a severe deformity, whereas it is protected, preserves vascularity. Recovery is faster with robotics. Is the alignment philosophy impacting the soft tissue release also is what we have to know. Mechanically, we all know that we have to release extensively, so the maximum damage is done there, followed by the least or no soft tissue release in the kinematic alignment. But concerns with kinematic is possible implant loading issues beyond certain angle at the tibia. So we have to come a midway where is restricted kinematic, where it acts as a boundary enforcer. So you know you are in that particular range, and beyond that you don't want to go and want to have that restricted kinematic. But where everything is the sweet spot is that functional alignment. Well, so these two articles summarize what is there. So the philosophy in a mechanical is zero neutral, but the risk of soft tissue impact is high. If it is restricted, it is moderate to low, release only if outside the limits. Functional, minimal bone cuts adjusted to the gaps. And kinematic has no soft tissue impact. We have discussed these two robos already, so I don't want to go into much details about this. So even the QS has been already discussed extensively. Now the strategy what we want to here apply is the yellow line is the midcorneal point beyond which we do not want to release if any robotic surgery. The green line what we see there is the initial release, and that alone is sufficient, and we can play around that release alone to do so many surgeries or align many knees. The red is very rarely needed, which we do not want to, and has to be used very cautiously. We'll just read three cases. I will not run through the entire case or exercise, it's just the final result. So this, with the same amount of release, in this knee we could just get away with a 0.5 degrees external rotation with 5 degrees slope and extension of 1 degree. That's it. And we could get almost all the gaps together. If we see the other knee, it is also balanced to the same tension, but here we had to give 2 degrees varus in this knee. Because the soft tissue tension is not the same in all the knees, we have to take that into consideration, respect that, and plan our cuts accordingly. So here only extension and external rotation with 2 degrees varus, which would not have been done if it were to be a conventional. Now this is another knee, also balanced to the same, but here we had to do so many changes which would not have been possible if it were to be a conventional. So we have distalized, we have extended it, we have flexed the tibial component varus, increased the slope to 6 degrees, which was 5 degrees to begin with, then again varus. So here we have balanced it quite well. So this is the scenarios which we have seen. Now, this is an entity where we all should also understand is the MASTI score, where once there is soft tissue injury or whatever release we are doing is concentrated in these 4 boxes. So the patellar tendon, the lateral, the posterior, and the medial. So what happening is these 4 quadrants will decide how much soft tissue injury was done or so much soft tissue we have released or what. The type 6 is completely untouched. We have not released anything, we have not done anything. Most commonly everyone falls under the type 5 where we have released just the anteromedial part, and everyone, most of the 80%, 85% of the knees fall in the type 5. Wherein if you have damaged one ligament or 2 or 3 or completely dysfunctional knees, type 1. So most of this score falls under 34 amount and 32 where we have a score which is at type 5. Now, Gurva sir team has come up with a modified MASTI score, which was published in IGO in 2025. So we also have to take that also into consideration. Now, coming to the results, as far as soft tissue release and the results with robotic are concerned, a robotic reduced the need for medial release compared to conventional, even with correctable and non-correctable deformities. This article by them has confirmed that. Now, what is the clinical impact? Is these articles summarize everything into this. So, robotic assistance reduces release rate to 12% from 29. So, the Londe et al. All these articles which are published has a comprehensive meta-analysis of so many things. So, if we can see, the robotic release rate has come down significantly in all knees, be it varus, valgus, or anything. So, now the long-term survivorship, not much of difference. So, whatever benefit we are gaining out of minimal soft tissue release and robotics is in the initial 6 months to 1 year. Later, everything is the same. But it is the initial 6 months what we need for the patient to come to the physiotherapy. So, like the opioid usage is lower in robotics, forgotten joint scores are higher, instability rate is lower, MCL injury is negligible, satisfaction rate is 90 to 95%. So, I would summary, extensive release, probably not anymore with regards to when there is robotics. Overstretching can defunction the ligaments. Surgeon's haptic field versus haptic boundary is what we have been discussing. But the results are consistent. With the same amount of release, you can play around and get this excellent to good results. Gap balancing and soft tissue addressed before cuts are taken. Short-term results are far better, long-term more or less similar, but sub-millimeter precision can be obtained. Thank you so much.